With anything that is so new, you need repetition, repetition, repetition for it to sink in, for it to be able to make some sense. And clearly, one of the things we have at our disposal are two very amazing approaches existing with us, one of them being the PIECES, and the other, of course, being the GPA. PIECES was really something my mentor, Dr. Ken LeClaire, had actually initiated, and I was a part of that way back when, in the early 90s, when it was starting to be formed. And then, of course, came GPA. But all along, I always felt there was something amiss in between those two steps. And again, as the literature evolved, as things got a little bit more clearer, I started to find myself working to see if there's a way we can find that in-between a jigsaw puzzle piece that's going to help us bridge the two. Because as I'll put things in perspective for you, the background of PIECES and of course GPA, there is still that in-between thing, and hopefully we'll make that clear. And certainly a lot of this is also in evolution. And again, any feedback anybody has at any time, let's keep it fairly informal. Let's make sure that we can have a dialogue. And again, any feedback to try and make this better and be more applicable is always appreciated, no matter how terse that feedback is. It's important. That's the way things evolve. So the idea of the meaning of behaviors, and I'm going to take you to a bit of a journey as to how this word meaning came into existence. Because we talk about it, but we really do need to have a conceptual understanding of where this came from, why this came from, and what this really means. The title itself, beyond PIECES and GPA, but really it is that in-between step we're looking at, because clearly those are very, very solid approaches, and I'm just gonna perhaps put them in a bit more perspective for you guys today. So one of the facts we have at this present point in time is, we've all been informed of this term, the white tsunami. In essence, what this means is the elderly people who are aging, and all the westernized world, certainly North America, we have what we call as an inverse population pyramid, which means we have way more elderly people at the top, and it's not a pyramid that's sitting on its base, it's a pyramid that's sitting on its head. And so we have very few young people because the birth rates are going down. And clearly the people who are here are aging. And we know, depending upon the age group, whether it's 65 and over, 80 and over, the percentage of dementias or neurocognitive disorders that it's called now is rising, and it's upwards of 20 to 25%. So we know by about 2030, our biggest healthcare budget for any westernized world will be managing neurocognitive disorders and related complications. And that's about 15 years out from here, and you know and I know how ill prepared we are. We can barely manage now with the resources we have, and every day we're informed there's less resources. So clearly nobody has really envisioned this. I hope people who are smarter than us have an idea what we're heading into, but it's going to be tough. I want to start with the understanding the approach to assessment, because that's really where all of this begins. Now, one of the things that I am held accountable to is what we refer to as a Diagnostic Statistical Manual, which is a DSM. And what DSM really is a reference book. It's got terms of reference and it's got diagnostic criteria. So basically what it says is, this is how a behavioral illness or a neuropsychiatric illness should present, and these are the determinants of what the illness should be, and if it fulfills those criteria, we should be able to give them a diagnosis of that, because that makes it for a valid diagnosis. And certainly in DSM-5, one of the things they have done is they've taken out all the in-between, the term that used to be called behavioral and psychological symptoms of dementia, that term has been taken out. BPSD is not in there. And they have moved on to major neurocognitive disorder with behavioral disturbances or without behavioral disturbances. But here is the kicker, is to be able to get to a diagnosis of behavioral disturbances. Whether you call it responsive behaviors, which I think is an amazing terminology to use. Responsive behaviors is a diagnosis of exclusion. And that's the key here you must remember. And what you need to do is you need to exclude a whole bunch of things. You need to make sure the presentation is not because of delirium. The presentation is not because of a mood spectrum disorder. It's not because of anxiety spectrum disorders. It's not because of psychotic spectrum disorders. It's not because of substance-induced. And certainly it is not because of physiological disturbances. So only and only after you have ruled all of these out can you rule in responsive behaviors. And that is the key thing. And it's important when we're all doing the same thing, we follow the same approach. And I know, as we practice in our daily work, sometimes I don't see that approach being followed, and I'll make that a bit more obvious as we go along. Now, what's also very important is to understand that DSM, or where they picked up these principles of labeling and diagnosing responsive behaviors or behavioral disturbances, was structured around the constructs which were put forth by Cohen-Mansfield. And everybody is familiar with that name because we use that scale. And when Cohen-Mansfield talked about quote-unquote agitation, what's very important for you people to appreciate is she was not referring to agitation as a symptom. And we'll give you a bit more. What she was referring to was agitation being labeled in every person with dementia who is presenting to you with behaviors and in whom you have ruled out delirium, you have ruled out mood disorders, you have ruled out psychotic disorders, you've ruled out anxiety disorders, and you've ruled out any other physiological disturbances. So in the Cohen-Mansfield agitation inventory, when at the bottom it says you've collected all the symptoms and it says, does the patient have agitation? Then it's not an automatic yes because you've collected 50 of those symptoms. It is only a yes when after you've collected those symptoms, you've ruled out all of these intermediary steps. And I just want you guys to reflect upon your practices to see how much do we adhere to this. So agitation, which is a term that clearly is being dispensed with, was not meant to be a symptom, but was meant to be a diagnosis or a syndrome or a construct. Now, this is how we approach. In my training, in nursing training, every other training, the approach to diagnostics is fairly simple. One of the first things you do is you obtain a history from your person who has cognitive impairment, and obviously you get as much collateral as possible. And then you do a fundamentally very important mental state exam. Now, mental state exam is the equivalent of a physical exam. Mental state exam is supposed to provide me with information that then allows me to either support the information in the history or discount the information in the history, which is no different than if someone came to you with shortness of breath. And you take the history, you do an examination, And if the pulmonary findings are all normal, then you're not going to be talking about certain diagnostics. You'll be looking at some other areas. Similarly, mental state exam is critical to any evaluation of what we do. And after we have done the history, done the mental state exam, we accrue those clinical findings, we collect all the positive findings, and then we apply them to the DSM diagnostic criteria to say, now, does it fulfill a diagnosis of major neurocognitive disorder? And if it does, then does it, after having ruled everything out, does it fulfill the criteria for the presence of quote-unquote behavioral disturbances? So this is what we should be doing. Now, here's the reality, and this is where my struggles began when I kind of woke up in what I was doing, because I, like everybody else, was trained on the same principle, same format, and that is 90% of people in the moderate to advanced stages of neurocognitive disorders will show responsive behaviors. And we all know, certainly the population we deal with upstairs on behavioral health and we deal with in nursing homes that we get referral on are really advanced, which is an MMSE of 9 or less. And those are the guidelines. Moderate is 18 to 10, and mild or advanced is 9 or less. And I think maybe 85% of the people really are 9 or less. We all interview our patients who have an MMSE of 9 or less. And I will leave it to you guys from your own experiences to draw upon as to what kind of clinical history will you get from this person. And if they give you some history today, will they give you the same history later on in the day? And then if I came back the next day, would I still hear the same information? I think the answer intuitively, clinically is no, they're not going to do that. Similarly, if I'm conducting a mental state exam, which is a question-answer format exam, then the chances are the answers I get today will be different from the answers I get tomorrow. That is, even if they remember my questions, which obviously they will not, because anything less than 9 or less is really, as we know, we're struggling. We're struggling. So what does that mean? So what that really means is that it does bring into question the validity and the reliability. And validity and reliability are two very technical terms. Reliability is responding in the same way every time you ask the question, and validity is the substance of what they're saying today remains the same the next time you ask in the context you do. So it does make it difficult. Now, here's where it gets a little murkier. We've all been told that there are standardized scales we can use. Because these people are not interviewable, because these individuals lack the reliability and the validity, therefore we should apply these scales. So let's just take a minute to talk about these scales. We all know CAM. It's again a phenomenal scale, but here's a problem. It has never been validated in anybody who's not cognitively impaired or who is cognitively impaired, and only later studies have talked about CAM being validated in people with very mild cognitive impairment. There is absolutely zero evidence about validity of the scale in moderate and zero in advanced dementias. The other scale we use, we've been told, is the Cornell. Now here's a problem with Cornell. If you really get down to reading the books and the papers, the person who developed the scale was very clear. He said, according to RDC, the Research Diagnostic Criteria, which is what he used, it's Alexopoulos, I believe, is the one who did this, and he said, this particular scale is only validated for determining the severity of a clinical depression. Once a clinical diagnosis of clinical depression has been made, it is not meant to diagnose. Even though they said there were certain internal validations done which could, but the intent behind the scale was never to diagnose. It was only meant, so it's like saying we use Braden scale here to determine the risk for developing skin breakdown, and then we start to say we'll use Braden scale to determine the severity, whether it's a stage 1 or 4 ulcer. I mean, we all know that wouldn't fly because that isn't the purpose of that. But having said that, I mean, these things have been ingrained in our practice. And frankly, I was as guilty way back when, thinking that is what it was, till I started to look at my own research and information. And then finally, neuropsychiatric inventory, which is, meant to diagnose anxiety or psychotic type of disorders, mood disorders, again, is a question answer. There is a very specific version of this scale which was attempted to be validated in long-term care. But really, the neuropsychiatric inventory as we know it today is meant to be for people of sound mind. It's not meant to be for people who have advanced neurocognitive disorders, who are MMSE of 9 and less. So that being the state of affairs, some wise people, starting with the individual who put forth the model of needs-based dementia compromised behaviors, started to say, we can do one of two things. We can either go on to develop scales, standardized scales, because we know clinical interviews are not going to give us the information. So we can use standardized scales and develop those and validate those. But that would be a challenging task because with an MMSE, I don't even know how many of my patients upstairs or in nursing homes can actually engage in an MMSE or a MOCA test. We'll do it, but it's like 1, 2, 0, not engageable, et cetera, et cetera. So to validate a scale was tough. So somebody said, this is going to be really tough. Let's take a step back and let's take an alternative approach to these responsive behaviors. And that's where they said, forget, quote unquote, the medical model of understanding this. Let's go to the humanistic model. Let's go to the simple social model. Can we understand what the individual is trying to communicate to us? And from their perspective, the meaning is not from my perspective. The meaning is from the individual's perspective. What is the person with dementia trying to communicate to you through their responsive behaviors and behavioral expressions? And that is how the impetus to meaning came about. And that is where we started afoot to say, we're struggling, we can't go any further with what we have in the traditional model, and let's try to do more in terms of the understanding and therefore the beginnings of meaning. And hence we are now always talking about what is the meaning, and all that stuff. So that hopefully puts into perspective for you the historical perspective of how things have evolved over the last 20 odd years, 25 odd years. And most of this really has come about in that period of time. So let's go to the first paradigm. So again, to put it in perspective for you guys, the purpose, and again, when PIECES was developed by Ken LeClaire and some of the other people, I forget their name, basically what they did was they said, can we find a very simple, everyday, clinical way to actually make sure we're all doing what we should be doing, which is take Cohen-Mansfield's constructs, which were then rolled into DSM, and then put something out in a way that we can sort of have everybody focus on it and it's not as threatening and intimidating. A brilliant idea. And that's where PIECES came in. But what they did was they went a little beyond what was initially intended in Cohen-Mansfield or DSM, which is P, which is physical, was meant to be to rule out delirium. I, intellectual, was really the pattern and severity of cognitive impairment. So they gave you one added thing in your working paradigm as you worked and approached things. E, which is emotional, was really meant to rule out mood, anxiety, and psychotic disorders. That is the E of PIECES. C is the capacity, and capacity really what they really meant was functioning. How is their cognitive impairment impacting on their function? So what they did was they rolled out a brilliant piece of evaluation for you, which said you can diagnose cognitive disorder, you can diagnose severity, you can diagnose impact on function, and then you can also rule out all these other things if you have the ability and the tools to see if by the end of the day what you have are responsive behaviors or not. E was environmental, which was to rule out milieu contributors, and social was really more self. And that was a concept that was thrown in to say, please do not forget, there is a person who is carrying the illness, and you need to understand the person. Hence the concept of personhood came into it. And we need to understand the psychological contributors or determinants to those behaviors by understanding the person who's carrying the disease. So I think it was amazing, this piece of work. So there were two proposals here. One was to identify variables which might be contributory, which is making sure it's not delirium, making sure it's not depression, making sure it's not anxiety disorders, making sure it's not psychotic disorders, making sure it's not, bladder retention or fecal loading or whatever. And once you've identified those, please address those. And once you've addressed those, then see what's left behind. If it resolves, great. You don't have to worry about anything else. But if it doesn't, now you have responsive behaviors or quote-unquote agitation in the most scientific ways of approaching and understanding, and then you need to understand the next steps. And if you cannot identify those contributors, which again, certainly at the stage when they come to me or my team upstairs, rarely do we ever find those contributors. I know as a frontline, I'm sure you guys and a BSO and everything else, you do all of that work anyway. And by the time you send them to us, all of that has been addressed and taken care of. So for me to go back and again sort of tell you to do the same, it doesn't really fly. It doesn't add to any more of what you've done because that's already been done. And if it's still there, then what they're really saying, the other concept of PIECES was that maybe then try to understand in context of the individual, the person who's carrying this illness, and understand what these behaviors mean. So this was the PIECES. I know it's a 2-day workshop. I don't think I'll ever have the time to attend it, but I'm sure it expands a lot on these concepts. But this really is what PIECES is all about. And then came GPA. Now, GPA, obviously, the idea was to add a little more to what we had with regards to PIECES. And so they came up with some principles, and I'm just sort of laying it out for you what their principles are. And the principles are basically holistic, which is really what PIECES is. Physical, emotional, psychological, biopsychosocial. That's the holistic approach or understanding of relationship between brain and behaviors, because clearly it's the brain that's got the illness, and it's the brain that is progressing in its illness, and therefore it's starting to do things. The second tenet of GPA is to understand that a person with dementia is unique in its emotional responses. Again, it goes back to PIECES, the self. Remember the person who's carrying the disease, because one of the conversations we have on our teams is this in keeping with the individual you knew, the mother you knew, or the husband or the wife you knew, or this is an aberration, or is this an accentuation? Because ultimately it's all about the person. And the third tenet was to describe emotional, environmental, interpersonal aspects of communicating with this individual who has neurocognitive disorder. Fourth is to choose strategies that don't flame, but extinguish behavioral responses. And finally, suitable, respectful protection techniques. So when I look at GPA, I kind of break it down into two parts. The first two bullets of GPA really is all about brain and behavior, because it is neurocognitive disorder. And the second bullet of GPA is understanding behavioral expressions. And I've taken out the slide because I didn't want to distract people from terminology today, but to help people understand behavioral expressions and responsive behaviors in context of personhood. What this component of GPA did was sort of took you a step back to understand brain behavior, and then all the other tenets of PIECES. And so that allows you to have a better understanding. But I think where GPA is invaluable is really the last three bullets, which is the approach, in the sense of how you approach, how you protect, how you preserve, and do all of those things. Because that is really the key of what GPA to me is all about. So when I was starting my research some time back, and I was looking at this and I was saying, you know, we've got great approaches, and we've got the approach to evaluation and diagnostics. We talk about meaning, but do we have any constructs that help us understand the meaning of what we see? And I didn't find any. And that's where my journey began, and that's where it has taken me, and we will go through that.